Welcome to Grand Rounds in Urology, the UroEdge Learning Center. I'm Diane Newman. I'm a urology nurse practitioner, pelvic floor specialist. I'm also the senior editor-director of GRU, Grand Rounds in Urology. I'm really excited because I'm here at the AUA and I have a guest with me, a colleague who I've done research with, practiced with. Her name is Ann Stapleton. She's an infectious disease specialist, and she's going to talk to us about antibiotic treatment and prevention. Welcome, Ann.
Thank you. So I'm going to go over some highlights of what we're talking about today in the update and review of the guidelines for recurrent UTI in women from the AUA, published several years ago. And I'll go quickly through the slides that you can see for yourself and that will be reflective more of older material. And I will focus on 2 new drugs and some changes that we expect in the Infectious Disease Society guidelines, as well as have already occurred in the European Urological Association guidelines. So my section of these guidelines and the talk today is about the therapeutic aspect of recurrent UTI. So our first point is actually starting at point 9 in the guidelines, which is always to use first-line therapy, which at present includes nitrofurantoin, trimethoprim-sulfamethoxazole, and fosfomycin. And these have been first-line for a number of years. Actually, in the 2011 IDSA guidelines, the medication Pivmecillinam was mentioned, and I will talk a little bit more about that later since it was approved last year. So the other point to make about this is that we don't want to use Bactrim or trimethoprim-sulfamethoxazole in areas empirically where their local resistance exceeds 20%. And that's pretty common in the United States right now. And as I mentioned, we'll talk about 2 new antibiotics today, which were recently approved, Pivmecillinam and Gepotidacin, which just got approval from FDA. So here's a little table with the current first-line therapies talking about cure rates, which are fairly similar, this antimicrobial spectrum. And what's notable here is that the narrowest spectrum is nitrofurantoin, and actually it does not get outside the bladder. So it's important to remember you need to be treating cystitis when you use this drug. For Bactrim, it's typical uropathogens, and fosfomycin can sometimes cover VRE, or vancomycin-resistant enterococci, or extended spectrum beta-lactamase producing gram-negative rods. So sometimes you can use it instead of IV therapy. None of these agents has much collateral damage. Resistance to nitrofurantoin has been stable for decades. Bactrim, as you likely all know, is increasing and becoming unusable in many places, and presently fosfomycin resistance is low. The therapy length for nitrofurantoin is 5 days based on studies and FDA guidelines, 3 days for Bactrim and 1 single dose for fosfomycin. Now here's our first new drug. So Pivmecillinam was mentioned in the 2011 guidelines, actually in anticipation of FDA approval, but here we are now, 13 years it took to get approval for it. It's a beta-lactam antibiotic. It's a prodrug of Mecillinam, which is an amidinopenicillin. It's been available for 40 years in Europe and Canada, and as I mentioned, it was in the first-line antibiotic list in the 2011 guidelines. It has a really good safety and tolerability profile. Every review of the drug, it mentions 30 to 40 studies of it or case series. It was FDA approved for susceptible isolates of E. coli, Proteus mirabilis, and Staph saprophyticus. And that's useful because Proteus and Staph sapro are not always covered by other antibiotics. So its coverage is broader than some other choices, and it does include ESBL about 90% of the time in the European and Canadian studies, Klebsiella species, Enterobacter species, and Citrobacter species. So that is a major advantage compared with our current first-line agents. So far, there's little resistance where it's been used, which again is in Canada and Europe. And I would mention here that most of those countries have a national health system and they have stewardship built into the available antibiotics. So we're not sure how it's going to fare here, but the American specialists in antimicrobial resistance feel that it doesn't appear to have any growing resistance, and it looks pretty good for the future. So we can hope that more free use in the United States does not result in increasing resistance here. One possible downside to it, it is 3 times daily dosed. And the dose range is given as 3 to 7 days, and that presumably is left to the provider to decide how long to treat. It appears to be safe in pregnancy, which is really an important point because we don't have very many drugs we can use in pregnancy. That is outside the scope of this particular talk today, but I thought I would mention it since it's useful to many people listening here. The main side effects are, as you would expect from this class of drugs, nausea and diarrhea. One weird thing about it is it depletes bodily carnitine stores. So there's some rare deficiencies in which you can't use it. Porphyria being a relatively uncommon or rare condition where you can't use it. Another point I should make is that you should not use it for a prolonged period in pregnancy because it is not thought to be good for the developing fetus to have a overall carnitine deficiency temporarily in the mom. The one caveat I have to say about this drug is I'm not sure of the timeline of availability in the United States. So the second drug I'd like to talk about, and a caveat about this is that this just got approved and it has not been incorporated into guidelines yet in the United States. So we don't know that this will be first line or not, but it was approved for uncomplicated UTIs. This is Gepotidacin, which is going out under the name of Blujepa from GlaxoSmithKline, and their hope is, and their plan is to have it released in the second half of this year. So this is the first new class of antibiotic approved for uncomplicated UTI in almost 30 years. So the Pivmecillinam was not new to the world, but this is new to the world. I don't think I can readily pronounce the class it is in, but I will try. It's a triaza acetylthylene bacterial type 2 topoisomerase inhibitor. So in that sense, it's somewhat similar to the fluoroquinolones, but what's interesting about this particular drug is it actually blocks two essential topoisomerase enzymes. So you need mutations in both to become resistant. In preliminary studies, there was really no resistance that arose. And it's thought that on a theoretical basis and in vitro testing that it would take a lot to get those two mutations. So this has great promise for being a durable drug to hit the market. There were two large clinical trials done in multi-centers comparing it to nitrofurantoin for non-inferiority. In both trials, it was non-inferior, and it was actually superior to nitrofurantoin in one trial. And it was FDA approved for, again, a very broad spectrum of susceptible microorganisms, and actually down to age 12, which again is beyond the scope of this lecture today that we're giving on the guidelines, but that's interesting in terms of treatment of adolescents with UTI. So the bugs is approved to treat if they're susceptible are E. coli, Klebsiella pneumoniae, Citrobacter fungi complex, which is a bunch of different Citrobacters that kind of act like E. coli, but don't always respond to the treatments that we would use empirically against Staph sapro and Enterococcus faecalis. So in summary, it has broader coverage and it fills some gaps that we don't have coverage for with our current first-line drugs. For example, Proteus mirabilis is intrinsically resistant to nitrofurantoin. So that's probably the most commonly used drug if people are reading guidelines. And yet if a patient has Proteus, which older patients and repeatedly treated patients may well have, it will not respond. This drug also has in vitro activity against ESBLs, or extended spectrum beta-lactamase producing organisms, and it is hoped that it will work in clinical practice. There were very few of these organisms seen in the trial, so they could not comment on that. Its side effects could be an issue. There's 16%, even in the FDA materials, of diarrhea and nausea. However, given the spectrum, I think this will definitely find its place fairly quickly. Precautions are similar to fluoroquinolones. It can cause QTC prolongation, which in your older patients is increasingly important because some have a QTC prolongation at baseline and they have a greater chance of having a medication that will also prolong QTC, which can cause fatal arrhythmias. It also should not be given with strong CYP3A inhibitors, and that includes drugs like the azole drugs for fungi, such as ketoconazole. In pregnancy and lactation, I put this in bold, there is insufficient data. There is a concern about fluoroquinolones, which are a similar mechanism in these states. So I think we should watch this space. They have established a registry for women who are given this drug during pregnancy. So that's the new material and the new drugs. Then back to the guidelines. So the next point is about why do we have alternate therapies? Now, interestingly, we include here beta-lactams and fluoroquinolones, and I've just told you about two drugs that are, one is in the class of beta-lactams, the other is a fluoroquinolone. The reason why we don't want to do this is that they have adverse effects, as mentioned in the third point here. Now, the QTc prolongation does exist with the Gepotidacin. There's no hint of any of these other negative side effects of fluoroquinolones in any of the data on the Gepotidacin, and the Pivmecillinam is a beta-lactam, but so far it appears that it does not have any adverse effects on the vaginal microbiome, which appears to be the reason why, if you give a beta-lactam, it is known to be associated with a very rapid recurrence. And many of us have seen this in clinical practice where we give somebody, well, for me, I get a consult where someone's been given repeatedly something like Keflex, and they keep having UTIs every 2 or 3 weeks. So that's one of the advantages of the Pivmecillinam as it appears in the almost 40 years of use in Europe and Canada. So the other thing on the last slide is the only single dose drug we have right now is fosfomycin. And the reason for that is that the risks were outweighed the benefits. And then for the duration of treatment, we want to use, with the exception of nitrofurantoin, which really does need to be given for 5 days. That was actually shown in a clinical trial. The duration of therapy, try to keep it to 3 days if at all possible. Single dose for the fosfomycin. And we'll have to see what ends up being stated in the IDSA guidelines regarding a 7-day treatment with Pivmecillinam, but my guess would be that they will advocate a 3-day treatment in most cases. So if you need to use parenteral antibiotics, there's often that this need arises because the bacteria produce ESBLs. They're usually only susceptible to carbapenems. So you're talking about meropenem, ertapenem, something like that. These are very expensive drugs. Meropenem is dosed more than once per day, so it's very difficult to give in an infusion center. They cost something like $3,000 a day wholesale, so it's really a big deal. So one thing to do before you do this endeavor to treat a very resistant bacteria is to check on fosfomycin susceptibility, which you probably have to ask for. Many hospitals don't do it, but there are many multi-drug resistant bacteria that will still be susceptible to that, and sometimes nitrofurantoin. So they don't always go along with the beta-lactamase production. In other words, the cephalosporin and penicillin resistance may not be retained by the fosfomycin or nitrofurantoin. And I just mentioned 2 drugs that in one case in vitro covers ESBLs, in the case of Pivmecillinam, 90% of the time it does. So those are things that may be more used in the future as Pivmecillinam, as a Pivia, the name they've given it is easier to say, as it becomes on the market. And again, consultation with an infectious disease specialist may be appropriate for resistance and management of such infections. And I would say that that may be true even for these 2 new oral drugs, because as you can see, some of the spectra of activity are broader, where a lot of people don't think about these bugs very much and don't think about other implications of having these bacteria. So we're always happy to help you. So thanks very much for your attention.
Thank you so much, Anne. You know, that was a really thorough review of guidelines, but also I like your review of the new medication. So let me give you a scenario. What if you have, I don't know, a 40-year-old woman, first time infection, symptoms are pretty severe. What would you start with?
If I'm doing empiric therapy, I would almost always start with nitrofurantoin, just because that's the most likely active agent. It does not treat infection or anything outside the bladder. And you do want to, if you're dealing with a simple cystitis, which is the other part that we're going to talk about later today at the meeting, just very quickly, the guidelines in Europe and very likely in the United States are now separating cystitis and UTI outside the bladder. So in the United States, we're calling it simple cystitis and complicated UTI. So in any case, the same principles. So when you're thinking about bladder restricted infection, you would prefer to treat something with a drug that only works in the bladder, so you don't have any chance of having collateral damage or side effects or effects on the microbiome outside that space. The reason it would be likely safe to use that is the resistance rates are pretty low. And most of the time when we see resistance in nitrofurantoin, it's because people have received repeated courses of antibiotics. And you mentioned this is the first infection for her. In terms of the pain and the severity, as long as it doesn't include signs or symptoms of infection outside the bladder, such as fever, chills, hemodynamic instability, and these are things that are now in the new EUA guidelines for UTI occurring outside the bladder, not just simple cystitis, then you're safe with nitrofurantoin. You can always use a urinary pain reliever in addition to deal with the initial symptoms. And then you would, of course, adjust once you got your culture back. And I probably would culture someone that age. All the studies done where you don't need a culture were really in people under age 40.
Tell me about, let's take a patient, multiple infections, so the repeat UTIs. Your resistance is okay, I mean, but would you go, I guess I'm trying to figure out, when do you go to the new agents? When would you start one of the new, because I think everybody's really excited about, we have these new antibiotics for UTIs, right? Do you think clinicians are just gonna rush to start using them in recurrent UTIs?
I wouldn't be surprised, but one thing that has been studied in the last couple of years thoroughly, we've said in these guidelines that you should look for empiric treatment of a person with recurrent UTI, a woman with recurrent UTI, you should look at the last culture, cultured bacteria from the last infection. So some studies have been done where people looked back to see how far should you go, and it's at least 3 months, and perhaps longer in some studies. But it does breed true in terms of what you're likely to get in the next infection is what you just had. So that gives you some guidance to begin with. You can see whether any of the available agents are actually appropriate for your patient at this time. Now, caveats that come up a lot in reality in practice is if the person may not have gotten a culture, and they may have just empirically been treated over and over. In that case, I probably still start with nitrofurantoin, but hopefully somewhere along the line, there's been some study that has shown whether or not they, for example, had an ESBL. Most people know that because they very likely were required to get IV antibiotics. In that case, fosfomycin may be helpful, or then you would have a good reason to consider Pivmecillinam or the Pivia, since it covered ESBLs in 90% of cases in a review of European and Canadian case series and studies.
So you're really saying we shouldn't right away jump on the new antibiotics?
I don't think so. One of the things that's emphasized in our original guidelines and from 2011, I'm sure will be emphasized in the ones to come, which should come out before October in this calendar year from the Infectious Disease Society, and is a new section and heavily emphasized in the European guidelines, is a need for antimicrobial stewardship to be always top of mind. So you're thinking about your choices, you're thinking about the effects on the patient, you're thinking about duration of therapy, always follow the guidelines. Hitting it harder never works. And it usually results in a fair percentage of the time, if not 100% of the time, in some patients, more collateral damage or development of further resistance, C. diff in some of the older patients, even younger patients, if it's broad spectrum enough. And so, you'd be thinking about essentially the shortest therapy with the most narrow spectrum antibiotic you can come up with. And always get a culture so that you can adjust that once you know, and which should be in 2 or 3 days. And you may need to treat a little bit longer than the 3 days we keep talking about if you don't get your results back for 3 days. But if you need to make an adjustment, you do. And you probably have to start over because you may not have eradicated the infection with the wrong antibiotic that you chose empirically, in good faith, of course. But, empiric is empiric. So we choose what we think is going to be best, and sometimes we get a surprise. But studies of empiric treatment with an antibiotic to which the bacteria is not susceptible have largely shown that it doesn't work. So we used to say, oh, it's all concentrated in the bladder and do a lot of hand waving, but it turns out in practice and in a few studies of that, it's not a good idea to say, oh, we gave you 3 days of Bactrim and it's resistant, but you'll probably be okay. Probably won't be. So I would advocate starting over in that case.
You brought up, several times about the culture, and a lot of times even urology, we just empirically treat women.
Right, I know. Yeah.
And so I struggle so much with the concept, if they have symptoms, we need to treat them, but what you're saying, if it's recurrent, we really should try to get a culture to determine what we're treating.
And that's in the diagnostic section of these guidelines itself. And, I think this is emphasized repeatedly in many places. Again, the original study showing that empiric therapy was fine was done in actually my institution, University of Washington, in people under age 45, all premenopausal, and most of them were coming to the student health clinic. So there are certain things about that demographic that are not necessarily applicable to the rest of the world. Some of the studies that we did in Seattle did include the group health cooperative, which is now part of Kaiser. So it was employed people somewhat older, enrolled in a HMO, but still they were younger people, and antibiotic exposure actually in those days was a lot less than it is now, and resistance was a bit less, particularly some bugs, it was a lot less. So I think we need to be careful at all times about thinking about that. It's one thing if you're running a college health clinic or something like that, or have largely young women in your practice. But frankly, in my experience for almost 20 years, most of those people send you a MyChart or whatever your, electronic medical record equivalent is, and they expect empiric treatment. And that's probably okay for those women, but for older women or women who've had a bunch of UTIs, you can always order them a culture and have them go in, and then MyChart you when they send in your empiric antibiotics, and then you just check the culture when it comes back. And they can still be managed without an office visit if that's how you want to do it.
Well, thanks so much, Anne. This was so informative. It's so current. And I was really excited because I know we have these new antibiotics and we are learning about them, but I'm not sure our audience is aware. So thank you very much.
You're very welcome. It was fun. Thanks a lot.